I warmly welcome everyone on this SRHR dialogue webinar on accountability in rights-based research and knowledge creation in sexual and reproductive health and rights. I'm Esther Kismodi, the Chief Executive of Sexual and Reproductive Health Matters, and I'm representing here a community who have been engaging in this very subject for a long period of time. As you may have seen in our announcement, this meeting is the first of a series of events we are hosting as part of our rights-based research in sexual and reproductive health and rights initiative. Before I'm introducing our panelists, I would like to take the opportunity to give some background about this particular initiative that we started with our partners. That I cannot name all of them, but I would like to really name the Bragg James P. Grant School of Public Health, Bragg University, Bangladesh, and the Program of Global Health and Human Rights at the University of Southern California, and independent experts who are forming our steering committee for this initiative, and which initiative is supported by the Bill and Melinda Gates Foundation India and the Open Society Institute. So just to really contextualize this discussion that we are having today, we started our thinking and dialoguing and our specific work from the recognition that sexual and reproductive health and rights laws, policies and programs across the world are increasingly influenced by ideologically inspired politics and rhetorics, which lack of basic of evidence on one hand, and often violate human rights and damage health on the other hand. We do realize that to address this problem, we need to invest in better understanding of rights-based research and knowledge creation. So this program has started from our side last July when we were holding various meetings in defining the concept of rights-based research from a multidisciplinary perspective. And our podcast is available on that thinking and dialoguing that has been released a week ago. As a result of this discussion series, we have divided our thinking and doing into modules, which address rights-based concepts that are particularly relevant to research, including the concepts of accountability, consent and autonomy, non-discrimination and equality, and participation. Each module includes a series of events, and unfortunately, these events need to be online at the moment, and we hope that we will turn to in-person dialogues as well as the creation of new materials such as an SRHR journal special issue with primers, roundtable articles and commentaries that will be launched very soon, literature reviews, and the podcast series that will be available online for all. So today's seminar is engaging with our first module of our thinking with the concept of accountability in rights-based research and knowledge creation in sexual and reproductive health and rights. Our purpose with this dialogue that will be followed up with another dialogue meeting with a closed working group style of discussion to enhance the discussion on how accountability can be incorporated into research and knowledge creation from a diverse, multidisciplinary perspective. We are focusing on the questions on how do we conceptualize accountability in sexual and reproductive health and rights research, and for what purpose. And many of these questions will be addressed at today's seminar webinar as well. How can a rights perspective be incorporated into the research process, from framing the research questions to conducting the analysis and assessing the outcomes, and in what ways we can incorporate accountability into the research process itself, and how can we contribute to a more equitable ethos in research. So after this introduction, I'm really warmly welcoming our panelist, Sana Contractor, who is an independent consultant and is based in India. Hi, Sana. Victoria Boydell, who is a research fellow at the Global Health Center at the Geneva Graduate Institute and who is based in London, UK today. Hi, Vicky. Marta Schaap, who is a global health justice advocate and health system and sexual and reproductive health and rights researcher, who is based in the USA, East Coast, New York. And Ana Lorena Ruano, who is an associate professor at the Center for International Health at the University and Research and Learning coordinator in Guatemala. Unfortunately, we couldn't connect with Ricky Cosiato, who is the executive director of Accountability International South Africa. We are really hoping that Ricky can join us while we are getting engaged in the discussion. So as a first discussant, I'm turning to you, Sana, if you could give us some introduction about the work that we are doing. You were leading a pretty massive literature review and analysis together with your colleague, Sapna Mishra, and you were able to draw some conclusions or at least discussion points about the conceptualization, about the methodologies, about the way of thinking, how we would like to engage with about accountability in the SRHR research process. Over to you, Sana.
Hi, thank you. I will just ask Alex if she can pull up my slides.
Good evening, everyone. My name is Sana and I'm making this presentation on behalf of my colleague Sapna and myself. This presentation is based on a review of literature that both of us have been working on for SRHM. To begin with, a brief introduction as to why we are talking about rights-based research on accountability. As this audience is probably well versed with, sexual and reproductive rights are an integral part of human rights and have been recognized in various human rights treaties, including as part of the right to health. But the realization of these rights is constrained by various structural factors, which are socio-cultural, political, and economic realities. This is because SRHR by its very nature is deeply contested along the axis of gender, but also other axes of power such as race, caste, class, ethnicity, disability, age, sexual orientation, and so on. Accountability is an essential component of SRHR research because it pushes us to look beyond the surface manifestations of a problem, be it a maternal health complication, a death resulting from unsafe abortion, forced or coerced female sterilization, or any other, and examine what processes within and outside of health systems allow these violations to take place. Human rights frameworks hold the state responsible for respecting, protecting, and fulfilling sexual and reproductive rights, and accountability is an essential component for guaranteeing remedy, redressal, and non-repetition. There has in fact been a growing interest in SRHR and accountability in recent times, but it tends to be limited in its purview, top-down, and not always emerging from local realities. We will talk about this in a little bit. So with this background, this presentation is an effort to synthesize from the literature what it means to conduct rights-based research on accountability in the SRHR field. It is based on a review, the methodology of which is presented on the slide. We sought to answer these three questions. How has accountability been conceptualized or defined in studies that are rights-based? How has the rights lens been incorporated while defining the questions, methods, and outcome studies? And in what ways have researchers embedded accountability within the research process? We began by using three sets of keywords related to accountability, SRH, and rights. We then narrowed down the selection, as you can see in the flowchart, first by eliminating some irrelevant results, then sifting through the articles to identify those that were most relevant to the objectives of the review, then consulted with experts to add a few more, especially in areas that we felt there were gaps, and finally ended up with about 100 documents from which we selected 50 that we felt were illustrative of the incorporation of a rights lens in the studies. In the next few slides, I will attempt to synthesize how we have seen a rights perspective being incorporated into the conceptualization, defining of research questions, and methods employed in the studies that we reviewed. To start off, the first thing that is evident in the literature is the varying meanings of accountability vis-a-vis SRHR. On the one hand, there is the rights-based understanding of accountability, which draws on human rights treaties, which view accountability as something that rights bearers can demand from their governments. On the other hand, there is an understanding of accountability which is somewhat managerial and focused on delivery of services and efficiency. An excellent analysis of World Bank reforms in this vein by Murthy and Klugman shows how within these reforms the idea of accountability has been limited to program management and service delivery and occurs within the boundaries of priorities that are defined through non-participatory processes. This means that accountability is sought for predetermined outcomes, which may or may not in their entirety advance women's sexual and reproductive rights. Drawing a distinction between these different understandings of accountability requires us to ask who is demanding accountability, from whom, and for what. It also requires us to identify the processes that lead to these accountability deficits, since the actions of frontline workers are influenced by various systemic factors involving multiple actors from the local to the global. There are a whole range of routes through which accountability may be sought, including political, institutional, health system, legal, professional, and social or community accountability. Further, the rights-based conceptualizations also make it clear that accountability is not just of public services, but also private, including that of donors and NGOs, and not something that just the front lines or even the national or domestic level, but also at the international level. It is important to mention here that especially in the past 15 years, accountability has received a great deal of attention in public health, and we identified at least 6 reviews apart from several other commentaries just in the SRHR domain. Based on learnings from the literature, these documents raise important conceptual concerns about how accountability is researched. Drawing on these, we have outlined 4 core principles that SRH and accountability research must incorporate from a rights perspective. The first is the interrogation of power, which entails unpacking the operations of power in different relationships in the accountability ecosystem, as well as the strategies that accountability efforts employ. The second is an appreciation of context and how it creates accountability deficits, but also interacts with accountability efforts to influence their outcomes. The third is using a systems approach, which is important because SRH violations are often the result of systemic failures in the health system as well as in society. If we do not take a systems approach, we run the risk of pinning accountability only on frontline providers and fail to address these systemic and structural issues. And finally, the fourth is the application of an equity lens to understand how and why accountability deficits arise and persist, and using this insight to inform accountability efforts. Assessing equity dividends of accountability strategies includes both the extent to which marginalized communities are able to drive them, as well as an understanding of how the workings of power within accountability efforts can impact equity. Coming to the research questions, in the next 2 slides, I will attempt to summarize the kinds of themes or areas that literature addresses across various types of accountability. Social accountability is probably the one category in this review that has the most literature, including several reviews from different standpoints. Most of the literature seems to be preoccupied with studying the impact of interventions. From a rights perspective, there are very thoughtful studies, both qualitative and quantitative, that seek to understand the way that power works and is transformed in these interventions, why interventions work or don't work, and what accountability within community means for SRHR, especially along the axes of gender and other social factors. This health system accountability literature seeks to unpack, among other things, how rules and internal policies get interpreted and implemented when they interact with highly unequal and power-ridden work cultures of health institutions, and the implications that this has for accountability to communities. The studies look at effectiveness of audit committees, patient feedback mechanisms, maternal death reviews, and structural and relational barriers to making these function effectively. The literature also examines the pitfalls of performance accountability. The second most common type of accountability that the literature discusses is legal accountability, that is, efforts to enforce accountability through the use of legal channels and laws. The themes discussed include the processes and outcomes of strategic litigation and what facilitates positive outcomes. The second important theme comprises barriers to seeking legal redress, especially in specific cases like violence or abortion, and especially challenges of non-recognition of sexual and reproductive rights of certain groups. And the third theme looks at the factors which facilitate or hinder the impact of positive litigation outcomes on actual implementation. Coming to international accountability, although there's been a plethora of international mechanisms to push for accountability, especially in the past 15 years, in domains like family planning and maternal health, for instance, there's very little, surprisingly, on the effectiveness or impact of these mechanisms. Studies that we found looked at the use of human rights laws and treaties, especially successful litigation in holding governments to account. And another two studies that we found looked at reporting to SDGs and the UPR process. Lastly, and this has also not been looked at very extensively, but the role of accountability in upstream relationships, as well as those with the private sector, like relationships with donors, INGOs, or private providers, as well as in global health cooperation, has not been studied enough. A few studies have attempted to uncover the accountability dynamics in such arrangements and problematize them using a rights lens. And finally, there are studies looking at specific accountability institutional arrangements like public-private partnerships and what accountability challenges that they pose. But this also is one of the under-researched areas in accountability research. In order to answer these questions, we will now look at some of the methods that have been employed. Realist approaches have been advanced as a possible way of unbundling complex accountability arrangements and processes and examining the dynamics with which accountability efforts bring about change and in which conditions. Case studies have been used extensively with different approaches. They allow in-depth examination of the workings of an accountability within a given context, drawing out common lessons across different contexts or comparing different cases to understand the role of context. This method also allows taking a process view to examine an intervention over a longer period of time. We found very few studies of long-term collective action campaigns or long-term litigation strategies, for example, which adopt a historical view using documentary review, cases, and primary qualitative data to make sense of the accountability seeking process, its journey, and what helps or hinders it and its outcomes. Ethnographic methods have been used in some studies which allow for an embedded observation of how mechanisms operate. Methods like institutional ethnography, for instance, have been used to understand how citizen monitors navigate their roles in Peru, unpacking the power dynamics that they encounter and negotiate. Ethnographic methods have also been used to uncover the relational and structural barriers to enforcing horizontal accountability within health systems. Mixed methods and quasi-experimental designs allow for quantifying outcomes, and when complemented by qualitative methods, they can provide a rich understanding of both processes and outcomes of interventions. But while qualitative experimental studies are seen as the gold standard in public health research, it is important to note that they are not necessarily suitable for the study of complex social interventions because they tend to flatten complexity rather than unpack it. As one methods review notes, quantitative data by itself is likely to raise more questions than answer them. Finally, content analysis of judgments, policies, and guidelines with a rights lens also provides rich insights into the logic underpinning these, and this has been used in some studies as well. The rights lens also complicates our understanding of outcomes to include not just health indicators or service utilization indicators, but also democratic and empowerment outcomes like strengthening voice, political capabilities, relationships between stakeholders, attitudes of providers, changes in discourse, and so on. Quantitative studies have attempted to do this by creating measurement scales, some of which have also been validated in different contexts. Finally, a comment on the third objective of this review, which was to explore ways in which the research process incorporates accountability. We found very few original research articles that explicitly indicate this, but this slide draws on the methods review and two commentaries that emerged from the WHO Community of Practice meetings on measuring SRHR. accountability outcomes, which attempt to flag some of these concerns related to accountability in the research process. The most obvious is the accountability to communities, since researchers or organizations are sometimes in a position to raise community concerns with government authorities. Another aspect of accountability is the need for researchers to examine and alter their own power in the process, vis-a-vis setting the research agenda, defining impact, and so on. Linked to this is the need to pay attention to the plurality of knowledge from a decolonial perspective and the hierarchy of disciplines that are involved in accountability research. Finally, the need to be transparent about the locations of the researchers and their relationship to both the donor as well as the intervention itself is important to address conflict of interest. Finally, I want to say a few words about the gaps that still remain. Despite this overwhelming body of literature, there is a disproportionate focus on social accountability, some on health systems and legal accountability, but very little on other aspects, especially the important ones around political and democratic accountability, that of donors and private sector actors, and international mechanisms. There's insufficient research on accountability that challenges broader structural and political concerns which have a bearing on SRHR. The evidence is skewed towards looking at maternal and reproductive health and doesn't look at a range of comprehensive SRHR issues. There's an insufficient interrogation of equity in researching accountability deficits, as well as the impact of accountability strategies. And finally, the evidence of impact focuses on bounded short-term interventions, but there's insufficient research on long-term social movement-based strategies. Thank you.
Sana, and I'm sorry for the technical difficulties, but I think it was an excellent introduction to the topic, and I would like to move now to Vicky. And Sana pointed out that however we are doing accountability research and researching accountability or incorporating accountability in research depends on the context. So what do we mean by the context? Can you please tell us a little bit about that? How do we contextualize accountability research in SRHR? Over to you, Vicky.
Great, thank you so much. Can you see my screen?
Yes.
Okay, I'm just going to wait for it to come into place. Thank you. Thank you, Esther, for the introduction. My name is Vicky Boydell, and I'm going to build on the excellent overview Sana provided on the different kinds of evidence there are on accountability and how people have gone about researching and what this tells us about the research process in the light of rights-based research and knowledge generation for sexual and reproductive health and rights. And I'm going to focus this presentation on something that Sana just flagged, which is how this rich evidence base has been generated within a particular set of circumstances. Because as Sana mentioned, and as we're all aware, context really matters. So over the last 10 to 15 years, there's been an increasing wave of interest in accountability in global health. In 2011, the UN Commission of Information and Accountability for Women and Children's Health resulted in a landmark accountability framework in this field. This framework very much specifically refers to a cyclical process of monitoring, reviewing and actioning to assess progress, document success, identify problems that need to be rectified and actions that need to be taken. So on this slide, I just wanted to give an outline of some of the key initiatives that have also aimed to strengthen accountability in relation to reproductive, maternal, newborn, child, and adolescent health over the last decade, and really kind of illustrate the increasing importance given to accountability. And this recent priority given to accountability in global health partly stems from recognizing that failures in health systems and healthcare, the denial of service and exclusion of certain groups are in fact accountability failures. And there's some kind of key moments historically of strategic litigation that's triggered legal accountability for services alongside mechanisms within the health system that aided performance accountability. That have all contributed to this increasing recognition of accountability for improving healthcare and health systems overall. I think one of the most, well-known cases of ensuring accountability for state failure to put in place access to life-saving, health services through strategic litigation is around the ARVs in South Africa that was led by the Treatment Action Campaign in the mid-90s. And another example related to performance accountability in the mid-2000s when WHO endorsed performance accountability within the health system through maternal death audits and verbal autopsies, and the report entitled Beyond the Numbers, which really made the case for looking at systems and structural failures, not just looking at individual failures, and the need to put into place, systemic course corrections. So in other words, there's a recognition that health system deficiencies are not going to be remedied by technical fixes only, but we need to really address the failures related to social and political functioning of the health system more broadly. Whoa, flew ahead, here we go. So this, for me, with this increasing interest, global health began to embrace accountability, and I think I think of this as kind of bottling accountability. So it can be best studied within public health and clinical paradigms. And this kind of bottling process, is very much about translating accountability into the logic of a bounded project that's more linear in terms of its process and development, with very predefined activities, steps, and stages. And second element of this bottling is that the success of accountability started to be assessed against criteria more typical of global health. And these criteria are very much derived from the hierarchy of evidence used within medicine that privileges very positivist approaches we associate with randomized controlled trials and some variation of experimental research study designs at the apex, as seen on this pyramid here. These types of evidence need certain types of research designs which are suited to certain types of projects. So there's a strong association and affiliation here. And this focus, this bottling process has, captured some very important evidence in and around accountability, particularly in relation to the health sector more broadly. So on this slide, I just wanted to pull out a couple of areas where we've seen reported outcomes in relation to social accountability, which is the area of accountability I know best. And this was and I think it really demonstrates that over the last 10 years, there's been a lot of real valiant efforts to show social accountability is effective in improving health-related outcomes. This particular document here is based on a very kind of relaxed review of randomized controlled trials and quasi-experimental studies of social accountability in health that we conducted in 2017 as part of a larger piece of work. And there are a wide range of positive outcomes in relation to service use and knowledge and attitudes and so on. But these findings tended to be reflective of a very specific variant of social accountability. These tended to be studies that focused on specific tools, whether they're community scorecards or audits that chiefly monitor and assess and contribute to the implementation of public policies. So this is just a very partial picture of what's been happening in and around social accountability. And Jonathan Fox, amongst many others who've been working in and around research around social accountability, have argued that by focusing on these short-term tool type projects, we run the risk of addressing the symptoms rather than the underlying causes of accountability failures, which tend to be quite often more upstream at higher levels of authority and governance. But by focusing on projects that are more amenable to positivist research, we may end up missing some very important multi-pronged, multi-level strategies that combine an array of different accountability tactics, whether it's social accountability with legal accountability, that have a great potential for encouraging accountability more broadly. And these can include the longer range ongoing political engagement with the state by social actors that Sana mentioned earlier, the multi-level civil society coalitions that pursue and monitor over the entire length of a supply chain or a budget process that are not just limited to one specific element of it, or the partnerships between kind of grassroots watchdogs and official oversight bodies that have a mutually reinforcing agenda to ensure accountability for failures in healthcare provision. And these approaches can be better suited to different types of study design. So the process and realist evaluations, the qualitative methods, the case studies, study designs that lend themselves to more interpretive analysis that Sana was outlining in her presentation, which follow a slightly different logic or paradigm to that of evidence-based medicine, but are nonetheless very, very valuable and provide important insights into accountability more broadly. And some of these approaches really actively address power in the research process itself, for example, through participatory action research. And I know my fellow panelists are going to share their insights into power in the research process shortly. So to wrap up, I just wanted to make two small points. And I think the first one is we just need to be aware that the research around accountability has evolved in a very specific and certain way. And this might have inadvertently privileged certain types of accountability and study designs. And there are a lot of efforts to address and rectify this bias that are very exciting. And there are a lot of good lessons to be shared more broadly. And secondly, in researching accountability, it's like a big umbrella covering a wide range of accountability practices, study designs, and paradigms. And we really need to be aware of that when we're coming into it, and to be able to situate our own work and thinking in relation to this broader piece of work that's taking place as a broader collective. So those are kind of the main points I really wanted to focus on. Thank you, Esther.
Thank you so much, Vicky, and I thank you very much also for leading us to Marta's intervention. Both Sana and you pointed out that understanding accountability and the dimensions of accountability, especially in the context of sexuality, sexual and reproductive health and rights, we need to engage with the concept of power, both in terms of how research, how SRHR outcomes, programs, and practices look like, but also in terms of the very nature of the research process. And I think it also very nicely corresponds to Adnan Hossain's point. Thank you so much, Adnan, for raising it, that Adnan points out that would be great to hear more about the tensions between various accountabilities, or even moving between accountabilities in the research process. For example, donor accountability versus accountability to communities on the ground. And any times there are tensions among those that is, in my opinion, also influenced by power. And I think we will hear about this point gradually in the upcoming presentation. So Marta, over to you.
Thank you, Esther. Good morning, good afternoon, everyone. Good evening, some of you. I'm Marta. It's 15 months into the pandemic and my internet is being super recalcitrant. I'm sitting on the floor of my living room and feeling a little out of sorts. It's not my usual working space, so hoping you'll all bear with me. I'm going to share my screen now. Can you see that, Esther?
No, we cannot see, Marta.
You cannot, okay.
Yes.
Perfect.
Super.
Okay, so I'm Marta once again. I'm going to talk about kind of the interface among SRHR, power, and accountability, drawing on some of the themes that Sana and Vicky introduced. So just want to start with this 30-second whirlwind tour of the concept of power. As many of you know, power has been widely theorized in political science and in the social sciences more broadly. And in the last 30 years or so, a sort of family of theories called critical theories have started to foreground the perspectives of the marginalized when we're talking about how power dynamics play out. These include critical race theory, a subject of great discussion in the United States these days, subaltern studies, feminist studies, etc. And then there are some more practical typologies that draw on multiple theories to provide a framework that can structure research. So one example that is fairly ubiquitous in the literature is Gaventa's power cube, which you see here on the right of your screen, where Gaventa looks at how power is manifest at different levels: global, national, local, different types of power, visible, hidden, and invisible, and different spaces where power can be manifested and claimed as well. So the working conceptualization that I'm going to use for this talk comes from a paper by Gita Sen and colleagues in 2020, where they state power often derives from deep structural inequalities, but also seeps into the norms and beliefs, into what we know as truth and what we believe about the world and ourselves within it. Its capillary action causes it to spread into every corner and social extremity, but also sets up the possibility of challenge and contestation. So in other words, power doesn't just shape the structure within which we live, we can also claim and contest power as well, bringing up the notion of empowerment. So next, I just want to talk briefly about the overlap between power and accountability, and to note that accountability dynamics, whatever they may be, right? So we talk about a lack of accountability. I'm going to argue here that there always is some type of accountability, and this reflects existing power dynamics. So governments, health providers, elected officials, private sector actors, civil society actors, they're all accountable to some power structure, basically at all times, right? But of concern to us as SRHR advocates is when the power structure to which they are accountable has aims that differ from promoting the right to sexual and reproductive health. So for example, governments may be more accountable to commercial interests. Donors may be more accountable also to commercial interests or to perpetuating norms around monopolies in the private sector, for example. Governments may be more accountable to xenophobic or religiously conservative actors than they are to promoting the rights of the voting public at large through the implementation of evidence-based SRH programs. So I'm going to recognize that accountability is a neutral phenomenon, but I'm assuming that all of us on this webinar have a shared vision to promote accountability for the realization of sexual and reproductive health and rights. So this also gets to the definition of accountability, and Sana described that there are some more managerial approaches to accountability, and a lot of these refer to answerability and sanctions in their definition of what accountability is. I want to propose this more expansive definition, which gets at the notion of the broader umbrella that Vicky evoked, to say that accountability refers to constraints on the exercise of power, such as rules or regulations, by external means or by internal norms, such as what we as a society or internally believe to be acceptable behavior. So next, I want to look at the question of power and SRHR. So in addition to being at the heart of accountability processes, power dynamics are also key determinants of sexual and reproductive health status, as well as funding, programming, and research, right? So in 2004, Piroshka, Aslan, and colleagues proposed this notion of looking at research content and research processes. So research on SRHR can address power in its content as well as in its conduct, or the way that it's undertaken. So on the right, you see an ecological model with the name of each level in white. And then examples, just examples, there are many more, of how power shapes SRHR at each level in black. So for example, at the interpersonal level, we can look at negotiations between partners regarding contraceptive use, or the way that providers treat stigmatized populations seeking care. These different expressions of power can all be the subject of research on SRHR and accountability, or the content of the research. On the left, you see how power can shape the SRHR research process itself. So I'm assuming this is intuitive to most of us on this call, because we all, in whatever our location, experience how prevailing power dynamics influence programming as well as the research process, such as like what questions are asked, which research is funded, who's on research teams. Even if we have a diverse team, how much influence and visibility does each actor have? Different individuals and different institutions. So to put together these three concepts of power, accountability, and SRHR, I want to propose that power dynamics shape every step of the research process, right? And so an accountable process centers the priorities and lived experiences of those the research is intended to benefit and seeks to transform rather than to just perpetuate the power dynamics that give rise to SRH and other inequities. Some of these power dynamics can include racism, casteism, gender inequality, neocolonialism, etc. And then in looking at research content, research on accountability for the realization of SRH should address the way that, using Gaventa's typology, visible, hidden, and invisible power shapes the issue under study, and to what extent a given accountability effort actually transforms these power relations. So again, both Sana and Vicky referred to the way that prevailing biomedical paradigms have framed what we understand to be the objective of accountability efforts and have led us to focus on more health service output indicators such as health service utilization rather than transforming power dynamics. So how can we do this? First would just be to systematically consider power in research processes, starting with the research question, the theories that we use, the methods, the teams that we convene. And then in looking at research content to assess whether and how accountability efforts actually shift power dynamics rather than just focusing on intermediate changes as part of the research content. So one example of this, again, I mentioned the Sen et al. Paper earlier in the talk. She and her colleagues described how various accountability for SRHR efforts have reinforced, accommodated, contested, and transformed extant power relations. Similarly, Karen Scott from UCSF in the Sacred Birth Study is creating a new validated scale, so this is firmly in the biomedical paradigm, to assess obstetric racism and other elements of quality of care. And this new scale draws entirely from the perspectives of Black women who led the process for its creation, as well as other racialized minorities. And the project as a whole is supported and led by a group of community-based organizations that act as community accountability partners. So this study is interesting in that it aims to transform power relations and to promote accountability to the purported beneficiaries of the research in the way it is undertaken, so in the processes that it's following, as well as in the results of the study, so in the content and desired impact. And so why is all of this important? The first point I want to make is a very pragmatic one, and just to say that program failures often stem from their inability to affect power relations in both sexual and reproductive health and accountability. So we can see short-term localized improvements, but the bigger changes that we seek are elusive, sustainable, longer-term changes. Changing power relations can be key to ensuring that changes are deeper and more sustained. And looking at these questions explicitly is one way of reflecting on program successes and challenges. So thank you. And I just want to end by showing you some further resources here related to this question of the interface among power, accountability, and SRH. Thanks, and I look forward to a discussion later.
Thank you so much, Martha. And I'm very pleased to turn to you, Ricky, to really continue from this point of challenging power relationship, but also in terms of contributing to a more equitable ethos in research, including on accountability, whether it's the process of how the research is happening, but also what we are researching. And I'm especially welcoming you on the day of International Day Against Homophobia, Transphobia, and Biphobia. And I'm extremely pleased that you are here with us today and choosing the topic of criminalization, because it can point to the very essence of accountability, the very essence of power, the very essence of marginalization. So thank you, Ricky, for being here with us today, and it's over to you.
Thank you so much, Esther, and thank you to the SRH team for having me. As you can hear, it's been a very hectic day with a lot of events and speaking platforms, particularly on this International Day Against Homophobia, Transphobia, intersex phobia, and all other forms that are interrelated to people's identity, expression, and bodily choice. My intervention comes from a perspective of working with Accountability International as the executive director, in which our primary focus is to proliferate accountability through ensuring that then communities that are affected by particular issues or by a lack of transparency around their existence, around their lives, around their rights, are actually foregrounded insofar as how we actually do research. And not only just as research participants and pools, but specifically, I think this was also mentioned by all previous speakers, emphasizing the point of participatory action research as a method for ensuring that our research outputs are not only just inclusive of communities that need the data, but that more importantly, the very communities that need data and evidence to be able to mount very strong and meaningful and impactful advocacy and reform processes are actually at the very beginning and through the process of the research to the end. And by that, I think we at this point in time continuously are aware of the various ways in which PAR as a methodology is used, where the design of the methods itself to the tools, the analysis and the reporting is really as it's led by communities. And I think that speaks definitely to the power dynamics that we ought to continuously be aware of that exist between researchers and communities that actually need the research and evidence. And it becomes incumbent on a lot of us as researchers, organizations, and individual researchers to continuously ask ourselves, what is this research meant for? Is it meant to meet the needs of I myself as a researcher, or do they actually meet the needs of the community that should be able to use this data? And I still stand back on the point that we often make at Accountability International. We're working on a new project that we have partnered with the HSRC in Human Research and Sciences Council, and looking to be able to actually speak to the empirical impact of using participatory action research versus academic style of research that often at times we have seen, and I speak from an African perspective, we've seen it being very extractive. We've seen it being very high level. We've seen it being very technical and not usable. And not usable for the very communities that it's intended. We've often seen quite a lot where research in and of itself is even inaccessible to the communities that the research was actually premised on, or that it was intended to actually benefit those particular communities. I speak this way without even using a PowerPoint in a deliberate sense of wanting as a transgender person to be able to bring an embodied response around accountability towards communities that actually need the research and communities that are affected by issues and matters that research is trying to be able to solve. And insofar as that is concerned from a trans perspective, I continuously am lamenting within an SRH and SRH research context, the kind of binarisms, the kind of cis-normative and heteronormative lens through which we actually approach research. I'm currently working with AVAC on a piece of research that we're going to be launching in a couple of weeks. And this is an analysis of the past 10 years of trans-specific HIV prevention science research. And one of the things that in analyzing a lot of sources of data that we've seen in the last 10 years, at least from 2011 up till 2021, is the fact that we continuously are seeing how, firstly, trans persons continuously are subsumed within other communities of persons. You will find that this is MSM in one instance, but further and beyond that, we continuously are seeing how there is a misunderstanding of the sexual and reproductive health related matters to transgender persons, because there is a heavy assumption that transgender persons exist as trans men and trans women. And what we know from research at this point in time is that transgender as an umbrella is a diverse community of persons, not only just trans men and trans women who have a gender non-binary person We're also looking in there at persons who actually identify outside of the gender spectrum. And question becomes, how do we ensure that in our research pools and in the populations that we actually are able to bring forth in data, we are not continuously reinforcing the invisibilization of other particular persons and the particular SRH-related needs and issues of those communities. And I think it is important that if we're going to talk about accountability within SRHR research, it's important that we speak about accountability towards recognizing and acknowledging diversity, even within trans populations and communities. And that, Esther, and everybody who is on here, greatly influences the manner in which we frame our questions, the manner in which we even foreground identities and pronouns of persons as we try and also assess the demographics that we are actually speaking to. And I think that is really, really important for us if we wish to be accountable and within an SRH research context, to remember that we are actually, as researchers, accountable to the communities whom we actually are researching, as well as communities whom the research is meant to be able to shed more light and transparency on their lives, on the issues that they actually are dealing with. And how we do this is obviously, especially within the work of Accountability International, is through continued accountability literacy training, where research in and of itself is not devoid from the capacity strengthening, where we understand as Accountability International that our work is not just purely for us to be able to present data and evidence, but that evidence needs to be utilized by communities in order to be able to hold duty bearers accountable. And to be able to do that, there is a process and a journey of being able to walk that path with affected communities, interested communities, in lead communities, to be able to actually translate research outputs into advocacy tools that are able to actually influence legislative, policy, and social services tailoring and structuring. And with that in mind, it is important that we continuously are ensuring that then we support various communities of persons, particularly marginalized communities whom we know are already excluded in the greater mainstream SRH discourse in various other parts. And I think, like you were speaking, Esther, it's a point that needs to be driven home about the very fact, then the positionality, I guess, as well, particularly towards communities that are already criminalized, and how our responsibility, or the responsibility thereof, of SRH research is to continuously move even legislative reform towards the end point of realizing that a holistic and integrated SRH discourse in actual fact requires that even some of these structural barriers be dealt with. And I think there's a responsibility, due responsibility on SRH research in that particular instance to continuously use and leverage the position it has of informing and of advising and of guiding, to be able to continuously also speak to these structural and systemic issues that already compound various other marginalized communities from actually accessing the full spectrum of sexual and reproductive rights, as well as health-related services thereof. Further to that, I think one thing that I have seen that we ought to be able to hold ourselves to account on, particularly within a sexual and reproductive health and rights discourse, is specifically around where we place, or the place where we do not find sexual pleasure within SRH discourse as something that is foregrounded as actually a part and parcel of sexual rights and sexual justice. And I think that's also a place where there's a need for sexual and reproductive health and right research to continuously remember and be cognizant and conscious of the advocacy endeavor that it needs to actually be driven by, to ensuring then that marginalized communities that are discriminated already on the premise of being criminalized by various other criminal provisions across the globe, that we continuously leverage the research to be able to ensure that then those particular issues are also spoken to, and those communities are brought to the fore. I mean, when you speak into that, in example, we are moving at this point in time, awaiting the ICD-11, which we will remember that the WHO, in actual fact, voted for the reform, that when I bring it closer to a trans and gender diverse perspective, that in 2022, as it comes into effect, we are seeing now where transgender persons are no longer, or transgender identity and expressions are no longer just contained, are no longer in the chapter on mental health or mental disorders, but it has now been moved into the new chapter that has been proposed, which is going to be looking at conditions of sexual health. And it is incumbent on us as a global community of SRH researchers and organizations to ensure that then those particular gains that have been made by efforts of various trans and gender diverse communities to ensure that there was a depathologization and a de-psychopathologization of trans and gender trans identities and gender expression in and of itself do not just become shifts that are not impactful insofar as ensuring that then in the ultimate services that need to be, or the package of services is actually conscious of the fact that we ought to now be speaking about gender affirming healthcare as a part of the holistic integrated sexual and reproductive health services that ought to be delivered to all persons. I think for grounding dignity and for grounding bodily autonomy as the guiding principle in that instance. One of the last points I'm going to be closing on, and as I talk about SRH research accountability, is on the very lens through which we approach the work. Because as I said earlier, I alluded to this, that there's a strong difference and there's a very strong ethical imperative on us to understand the difference between capacity strengthening and capacity development, where we problematize a lot of SRH-related research and general research is where it comes with a very global northern perspective that sees global southern counterparts as lacking in capacity, and as such they need to be capacity built. Whereas we continuously in the work that we do, and you particularly ground participatory action research as the very methods that we do this work with, you get to understand and appreciate the differential levels and degrees of lived realities and experiences and expertise that ideally showcase capacity that we as researchers need to be coming into the fold with an intent of enhancing, supporting, providing technical assistance to be able to ensure that then that capacity actually becomes impactful and actually meaningful for the communities that are very much affected. And as I conclude, one of the most important, I think, outputs of the work that we do as Accountability International has been, like I said, walking the journey with communities as we do research, particularly within an SRH research context. We do quite a lot of consultancy work as well as projects of our own that are continuously geared at ensuring that out of research, there is shift, either to laws, either to policy, or to social services. And to be able to do that is to also continuously work with communities to be able to understand the various global SRH and global health commitments, and bringing it even down within an African context where some of our work is also, we do a lot of work globally and also on the Pan-African level. And a lot of our work has also been geared towards actually ensuring that we popularize existing health policy instruments. Within an African context, we've had a revision of about 5 major health policy instruments in 2015 that up until 2019, because of the work that we're doing as Accountability International, had no accountability frameworks attached to them. There were beautiful policy instruments that were put into place, one of them being the Maputo Plan of Action at the African Union level, one of them being the African Nutrition Strategy, and all of these lacked a very important framework that needed to be able to enable us, civil society, and even as and duty bearers being the states and governments, to be able to measure the work that is being done to ensure that then these policies do not just look good on paper, but they actually translate into social shifts that need to be felt as changes for communities that are affected or communities of marginalized persons. And in so doing, then a lot of our work has been on ensuring that then civil society, we work with civil society to continuously bring to the fore what actual commitments exist, what actual binding documentation, be it at global or continental level, that exists that we as civil society ought to continuously be the watchdog on. That way, I think, Esther, it becomes very impactful to be able to see our research then being utilized in a way where it really speaks to the needs of community, because I continuously lament beautiful research, particularly within an SRH context, that does not necessarily change somebody else's life on the ground who currently is unable to access SRH services because of COVID-19, a transgender person who's not able to access gender affirming healthcare because of discriminatory policies and law, where a person who carries sex work status is not able to report certain particular sexual violence because of the criminalization of sex work across board. And this is the way in which we continuously ensure that we really strengthen civil society to continuously not only be proficient researchers to be able to provide data transparency, because I think data transparency is the key tenet towards accountability, because without data, then we aren't able to speak to any particular subject matter. But beyond that, it is important that once we have the data and there's transparency on that there's meaningful dialogue that needs to be able to be supported to the point where action that needs to be taken is also followed through in that regard. And it requires a very deliberate effort of ensuring that SRH research itself understands its position within the greater wheel of accountability and ensuring the kind of social, legislative and policy reform and changes that we seek. And in that way, I think we will be very, very, very impactful with the kind of evidence and research that we actually bring to the fore. On the last note, and it's just to summarize, I think, everything else that I have already spoken to, is to ensure that SRH research in and of itself is foregrounded on a gender diversity and a sexual diversity kind of lens and framing. In that very manner, we continuously are pushing the envelope and not necessarily reproducing framework of data as it has been framed and exercises that have been done in previous. And I think that's the way that we can be able to see we've been accountable in ensuring that we, even ourselves, are not exclusionary to other people, or we are not reproducing the binarisms and the normativity that many other persons actually bring into this work. And with that, I think I will leave it at point. Thank you so much.
Thank you so much, Vicky, for your fantastic intervention. And I feel that you both brought so many points into the discussion that needs unfolding, further discussion. And I hope that we continue to engage. And based on many of your points, as a follow-up, I would like to turn to Anna Lorena, who will talk about an accountability action research example, bringing the example of how human rights defenders from the indigenous communities in Guatemala brought research into action, and how were they be able to do it, how difference it makes, and how it can actually, the research and the knowledge that has been gained through this process actually turned back exactly to the point what Ricky, you said, that it was created by communities and used by communities with their own understanding of their rights and needs. So Anna Lorena, it's over to you.
Thank you very much. Ricky, I also felt that what you were saying was such a nice way to introduce the work that we do in Guatemala. And so I hope that seeing our example of how research can be not devoid, but intricately linked to capacity strengthening in different communities can be done. So let me just start the PowerPoint here. I hope everyone can see it okay. So today I am going to talk about the sexual and reproductive rights of indigenous people in Guatemala. This is the experience of the community defenders for the right to health and the way that we link knowledge creation to practice. So Guatemala has 18 million people, and about 47% self-identify as indigenous, although because it is self-identifying and there's a really heavy load of racism in the country, it's probably more like 80% of the population. 60% of the people in the country are poor, but 80% of indigenous people are poor. And they also exhibit some of the lowest rates of literacy in the country. And women, indigenous women, are 3 times as likely to die from childbirth-related complications than a woman from my ethnicity. And overall, there is a lack of quality public health services, and it affects the excluded people, the poor people, those in rural areas, and indigenous people even more intensely. So our approach at the Center for the Study of Governance and Equity in Health Systems, CEGS, is to take independent and autonomous citizens and support their action. And to do that, we use the existing legal framework, which includes both national and international norms, policies, and standards. And we create and implement rights literacy campaigns among the general population, specifically focused on areas with high density of indigenous populations. And we build capacity among community leaders to monitor public policies and services and demand accountability from authorities, and also to use strategic advocacy to engage with the state. In addition to the health sector, we need to engage with Parliament, with the judiciary system, with the National Ombudsman Office, and with other places. The citizens that we train to act on using social accountability are called the community defenders for the right to health. They represent 38 municipalities and 6 linguistic communities. Although the number of active defenders is hard to pinpoint at any time, it's about 130. They promote human rights through rights awareness and through the defense of rights. And they are trained in collecting evidence of rights violations, and they use it to support social accountability processes, like advocating for the improvement of sexual and reproductive health services and to monitor service performance overall. They also support and accompany patients who may have grown weary and afraid of going to health facilities that routinely abuse them, or where they feel discriminated against, or where they don't speak their language and so they are unable to communicate. Community defenders for the right to health also document poor working conditions for sexual and reproductive health and service delivery. Guatemala during the lockdown experienced an increase in human rights abuses, and lockdown led to expanded governmental power, at local and national level. And this resulted in very many serious abuses of power. It got to a point that in some communities, women were not allowed to go out of their house alone, and they had to go with a male chaperone wherever they were going. And this, of course, negatively affected single mothers and female-headed households and limited privacy when seeking sexual and reproductive health-related services. This is especially important in indigenous areas because many husbands oppose the use of contraceptions, and so women use it in secret. And so being unable to go to a health facility without a man escorting them also puts them in a place where their privacy is not respected and they can't have the services that they need without this becoming a very heavy issue at home. The suspension of all non-COVID related services led to an increase in home births, and traditional birth attendants replaced more skilled birth attendants. This is in principle not a problem because many indigenous women feel more comfortable dealing with TBAs who are respectful, who know their language, who will let them use culturally appropriate activities around childbirth as well, instead of a cold birth facility that discriminates them, abuses them, or even conducts unauthorized procedures on them. The problem lies in that birth certificates are only provided to children that are born in health facilities or that come with approved TBAs. And that's a little difficult because who gets approved by the health system is complex and not necessarily transparent. So many families couldn't register births. We identified at least 15 cases of denial of birth registration in one of Guatemala's 22 regions alone. And we suspect that there were many, many other children that were unable to have birth certificates. This will reverberate throughout their lives, but in the short term, it won't allow them to get right to access school or to access any vaccinations or any services at health facilities. So what we need to do is to do more research, like Ricky was saying, and investigate the nature of these abuses. But we need to use multidisciplinary approaches that strengthen the work that community defenders for the right to health do. So the way that we work at CEGS is always thinking about how we can support and improve the work that the community defenders are doing. And we are very clear that the way that we produce knowledge, or what knowledge we produce, is meant to be fed back into our social accountability strategies. We also want to identify mechanisms to report human rights violations and abuses of power during the pandemic. And we want to improve our understanding of how to effectively engage with the complex and intricate administrative hierarchy of the Ministry of Health to monitor better performance of health services. And how are we doing this? Well, after we have trained the community defenders for the right to health in different ways of collecting data, specifically qualitative data, which we have seen is the most useful one when it comes to impacting with policymakers and decision makers, we have provided over 100 smartphones to them. And they use these as tools because it helps them to document, to monitor, to learn, to share, and to organize better. The smartphone has a camera, so they can take pictures and videos of health facilities that are run down or completely destocked. They can also take videos or voice messages interviewing service users that were aggrieved or that were abused or that encountered human rights violations when seeking services. All of this helps us to be more effective in the work that we do around social accountability. By developing a learning program around the right to health, we're able to teach about the legal framework, how to work with authorities and hold them accountable, and how to use basic advocacy tools. This is especially important in a context of a failing state, that in many cases for Indigenous people is a completely absent state. They don't feel like they're citizens because they don't feel part of a country. And so understanding that you have rights is very difficult among populations that have never been thought of as Guatemalan. To do this, we hold bi-weekly Zoom meetings for sharing learning experiences, and to discuss political context, COVID-related issues, and other topics. This used to be in person, and we used to do it with a local tutor that would be there accompanying reflections, because we believe that getting together, working together, realizing that we have the same struggles and that everyone in the different communities that the community defenders for the right to health come from are facing the same issues. However, Zoom has ended up being a way for us to stay engaged during COVID restrictions and for the community defenders to grow closer together, even if they don't have the tools or the ability to travel. So how is it that we link knowledge creation to practice? Well, we work in learning cycles. And this helps us to raise awareness on the roots on the complex issues are affecting sexual and reproductive health rights. And this facilitates deeper reflection. This learning cycle is the cycle of action for the community defender for the right to health. So once we say we identified an issue, a rights violation, like for example, not being able to get a birth certificate because your child was born at home, we gather evidence. We interview the families, we take pictures, we document that the health facility was closed and there were no services to be offered. And then we prepare for engaging with authorities. This means that we take the evidence that we gathered and we sort it and try to find a way to tell a story through it. So we can present the evidence and then know what the demands that we need to have are. After we have met with the authorities and presented our evidence, we see if we need to adjust our strategy. If the authorities were supportive and they are in favor of helping us, then we adjust the strategy. If they were not supportive and they deny that something was happening, we adjust the strategy by implementing follow-up actions. And then by verifying the resolution of the demands and then planning a new cycle and starting again. So this is how we link knowledge creation to practice among the community defenders for the right to health. But us as an institution, what guides us is this. We want to build processes that continually build awareness and raise consciousness. We acknowledge that without citizens, a citizenry that is strong, trained, critical, and engaged, the conditions will not change. So this is our theory of how we think that we need to work with communities to awaken them, to raise awareness, and to engage them in a way that is profound and deep and that helps them gain the abilities, the skills, and the tools for impacting the poor qualities in the health services that they encounter. This is it. I was trying to be very succinct.
Fantastic. Thank you so much, Anna Lorena. You really captured many of the points that we raised before, and you took it to a much deeper level to understand us, that how does this actually work in practice. We don't have too much time left, But I would like to go back to the panelists and really just if you could have 1 minute reflection on some of the questions, interesting questions that were raised. And this include, and I'm just saying it, and then you could see that who has the inclination to respond to that. Sana, I was thinking there was a very interesting question about that why the classification of the accountability is important. It would be nice to see that how we are moving in between various accountabilities. Vicky or Marta, it would be, or both of you would be great to reflect on that, how in general accountability is both a lens to understand differential accountability within a health system and a process advocating for change. And also how much we learned about the success of internally versus externally led accountability mechanism. And maybe Ricky, if just really for a minute, if you could talk about that, we talk about the rights and needs of communities, both in the context of research and translating to them into practice, when actually power relationships also exist within the communities themselves, and how do we address those? So really just for 1 minute reflection, it's very artificial to make it 1 minute, but I would love if we could give some responses. So Sana, around how we move around accountability.
So yeah, this question of this classification of accountability, I find it odd because in the research, in the literature, you often find articles that focus on one kind of accountability. We found very few that actually look at the complementarity of different kinds of approaches. Whereas in accountability practice, what you normally do is you push levers at every stage. So you engage with legal processes, you engage with political processes, you engage with the health system itself. And there's a sort of synergy of all of these that finally pushes the system to work. And there are a few articles that do see this kind of complementarity between the different kinds of strategy. But as a practitioner myself, I feel like in real life, we do all of it together. Whereas in the research, you tend to see it in verticals, which is not very helpful. And there are tensions between the different kinds of accountability. Like Marta said, everyone is accountable to somebody. And I mean, I'd encourage you to see Sarah Van Bell and Susanna Mayhew's work, for instance, where they look at a project in Ghana and find that actually the accountability to the system and to donors is actually much more strong than it is to community themselves, and they make a call for strengthening of public accountability. And there's also another study by Stephanie Top and others, which shows how administrative accountability tends to stay on, but social accountability weakens even with upscaling. And so there is this kind of power dynamic, and that's exactly why unpacking the power dynamics is important. And as much as that is important, it's also important to look at accountability more seamlessly as strategies that we use depending on what works at what time. And that's exactly what the limitations of these bounded interventions is that they do not have the time or the scope, and there are definitely methodological challenges with making sense of how each of these things works. But in the public health paradigm, where you're obliged to tease out the impact of social accountability interventions versus others, there's this tendency to see the field as a kind of experimental field where and an assumption that you can actually do that, but that's not really true because a lot of other things are going on in the context anyway. So yeah, in a nutshell, that's my take on the.
Thank you so much. Thank you very, very much, Sana. Vicky.
Thank you, Esther. And I think much like Sana was commenting, I think that accountability can perform several different roles, such as, looking at the public actors and, making sure the health system delivers on legal entitlements within the health system, and that's happening, and the different accountability relationships within that broader ecosystem are working together, building off each other to ensure that the ideal health services are being provided. But I think, as both Ricky and Anna Lorena pointed out, that sometimes those legal entitlements and the standards that come with them are very inadequate, and are at worst actively discriminating against specific populations. And so we need to change those legal standards and of care that are anticipated. So we need to work on both sides of the coin as such. But I think, sadly, as Sana mentioned, there isn't so much work that's looking at mapping those two processes together. There are quite a few reviews that have been done over time that make the case for the need to have multiple different accountability tactics working together. There's the work of Jonathan Fox reviewing what is the evidence around social accountability. There was a large review done by WHO and USAID called Marshalling the Evidence, which came to the same conclusion that we need to look at accountability in the round instead of focusing on specific tactics. And there was also a DFID evaluation where they looked at all their great portfolio of investments in this area, and they came to the exact same conclusion. But this is where I think we possibly fall short in terms of our methodologies, because we're looking at performance and social and legal accountability, and the challenge is getting some comparability across them, because the kind of outcomes we anticipate are very different, and those outcomes or findings or types of evidence we're looking at are come from very different kind of approaches to knowledge and to science. And so we have a true methodological challenge, but there is really exciting work out there that's been worked on in the last couple of years that I think tries to marry up some of these different study designs. But it's very much an iterative process, and what I think is exciting is I think there's been a lot of collective learning on how to build on the different methods that people have been using over time. So I think it's a very constructive and generative time in terms of this knowledge generation.
Thank you so much. Thank you very much, Vicky. And we are running out of time, but I'm turning to you, Marta. It was actually your questions to Ricky about the looking at the power dynamics in communities. Could you, unfortunately, Ricky had to leave, but could you just say a couple of words about this point, because I think it's extremely important as well, and then we need to sum up the meeting. Thank you.
Okay, I was working on something else in my head, but to answer your question, I think that often, we've all spoken about this kind of flattening that happens when we try to put a round peg in a square hole, right? We have all this rich work that's happening on the ground. We're trying to package it or bottle it, as Vicky said, for purposes of bounding it, making it explainable, and making it accessible to donors, whereas there's a whole kind of panoply of things happening on the ground, from more ground up things to top down things, et cetera. So I think that often as part of that flattening, there's this assumption that community engagement is an unmitigated good and net positive. And so I think, there's so much work that's been done on violence against women, on issues affecting women in particular, and I think increasingly looking at queer rights and other things to understand how power dynamics and caste and race, power dynamics within communities influence what gets elevated as a community priority, and how different individuals interacting with each other shapes what we understand and they understand to be accountability, and sort of whose voice gets left off of a community-driven priority setting process. I think that's something very important to consider, and I don't think that prevailing social accountability approaches are necessarily the answer to that problem, but I think it's something that we all need to think about in research and programming.
Thank you so much, Marta. And I think it's very nicely corresponds with our comment, and also Anna Lorena, to your presentation. when Priya is pointing out that if there is a danger about being instrumental, about accountability, if linked with deep community-based or and designed rights-based perspective, the research outcomes might be very different when in design, the intervention is designed for specific outcomes. So we have a lot of thought and super rich discussion to think about and take it forward. It was really a flavor about how we want to take this work forward and how we encourage each other to actually really contribute to a more equitable ethos of research, working with communities and investigating power dynamics and exploring different accountability mechanisms and really learning from each other how we either examine accountability for linking it to action or integrating accountability into ongoing research as an imperative to successful outcomes. So thank you so much for our panelists, Sana, Vicky, Marta, Anna Lorena, and Ricky, and thank you so much for all of your contribution and ongoing discussion going on in the chat. We are really looking forward to further engaging with you. Please look for our podcast. We are hoping to produce a podcast on this conversation. We will put out articles and we hope that we will have further dialogue meetings. And as SRHR, as a journal, we are really looking forward to receive papers from you that is engaging with the content of accountability and other rights-based research and knowledge creation perspective and approaches. Thank you so much for the panelists and thank you so much for the participants. Have a nice continuation of the day or have a nice beginning of end of the day. Thank you very much for being with us today. Bye-bye.